Our next speaker is Nancy Lane. Nancy's endowed professor of medicine and director of the Musculoskeletal and Aging Research and Education Center, director of the Academic Geriatric Resource Center, and vice chair faculty development at the University of California, Davis. She received her bachelor's degree there, her medical degree at UCSF. She was a resident at Mount Zion and fellowship in Palo Alto at Stanford. She's got a number of awards, associate editorships, over 200 peer-reviewed publications, over 65 invited reviews and book chapters, and she's going to give us an update on osteoarthritis.
It's great to be here this morning, and I thank David for that wonderful introduction. And I'm going to ask your forgiveness because I changed my talk last week and actually this morning. So you have a little more information probably in the syllabus that I'm going to talk about, and I'm going to try to inject some enthusiasm into this disease that we all know and see and treat, but yet often feel frustrated about. And by telling you, trying to get some excitement here, that there's a few things that have occurred and hopefully a few more exciting things that are on the very near horizon. Okay, with that I will mention that I have no disclosures related to this talk. And let me start by acknowledging the management of OA. Best stated is, if there is an illness for which people offer many remedies, then what do we all know? We can be sure that the particular illness is incurable, and that's probably OA, but that's okay. I'm going to start a little bit now talking about some novel or different therapies for OA than the traditional non-steroidal anti-inflammatory drugs. And the first thing I'm going to talk about is a central pain inhibitor. And over the past 10 years, I think rheumatologists like all of us here this morning have made a number of observations about our patients treated with serotonin reuptake inhibitors about their joint pain. And people treated with fibromyalgia have often commented to us that their joint pain improves. So it was actually surprising to me. It took about 10 years, and a serotonin reuptake inhibitor was actually studied for the treatment of knee OA. And this is one of the small studies that was done where patients with osteoarthritis of the knee that had pain were randomized to placebo or duloxetine and followed. Although the study was only 16 weeks, you can see that compared to placebo, within about 3 weeks, there was definitely a separating from placebo in pain, both in patients that were randomized and patients that finished the study. And there was a placebo response, which we're all used to, but the therapy appeared to be more effective. And then the second outcome was function. And if you follow my curves here, you'll see that the patients that were actually on Cymbalta had, or duloxetine actually had an improvement in function. So while this is not a major step forward, I think it reassures us that patients that is in many of our patients a central pain component to OA. A couple of the other speakers this morning, or another one of the speakers this morning or today, traveled with me to the osteoarthritis conference last weekend, and we saw a number of presentations about functional MRI in patients with chronic pain and OA, and sure enough, those patients have abnormalities or changes in their functional MRIs, the CT of the brain, with pain, and so there probably in many patients is a central component. I'm not saying one should immediately start all their patients on serotonin reuptake inhibitors, but I think this data is somewhat reassuring that there is that subgroup of patients that may be able to better tolerate their pain and have some improvement with this type of therapy. And from that respect, I think it is somewhat novel, and I think we'll see more work in central